Okay, good morning, everybody. It's lovely to see you all here and everybody who is online. It's a real privilege to be with you and see some familiar faces. Basically, I wanted to provide you a brief overview of Pompe disease, where things are and what is the future, how the future is looking for us. I think half an hour is definitely not enough, maybe 30 hours will be more and better, but I will try to give you an update. So going forward, these are my conflict of interest and just the objective of the talk. I will give you a brief overview of Pompe disease, but then focus on what is most recent developments in both the enzyme replacement therapy, the substrate reduction therapy, and gene therapy. And of course, I think this audience is well aware of what Pompe disease is. It is a rare genetic disorder result of mutation in a gene called GAA. The gene is important because it encodes protein or enzyme acetylglucosidase that is essential into the process and metabolism of glycogen. So you can see, it doesn't show there. So you can see, no, okay. And I have to apologize for my cough. Okay. So you can see the enlarged lysosomes that are containing really a big amount of glycogen. Glycogen is polymer of more than 50,000 molecules of glucose. Unfortunately, the enzyme that has to work and metabolize the glycogen is not functioning. It can be completely absent or it can be in a decreased activity. Depending on that, a patient can have really severe onset. Those would be children who have less than 1% activity. Compare it to patients who have some residual enzyme activity. Their presentation will happen a bit later on, either childhood or adulthood. Usually the percentage activity is less than 30%. This is a condition that is seen all over the world. Of course, the frequency will vary. You can see in French Guiana, for example, the frequency is really quite high, one in approximately 4,000. The general accepted frequency is maybe 1 in 40,000 for infantile onset and around 1 in 146,000 for late onset Pompe disease. As a genetic disorder, there are now more than 600 known spelling errors or mutations in the gene. The gene is rather large. It has 20 pieces or exons that are coding for the gene, and you can see that there are some graphs that are higher showing the number of mutations or spelling errors in that specific part of the gene. And depending on the mutation, depending on how much residual activity a patient can have early on or later onset disease. The clinical presentation, you guys, I think, are aware well of this. We have two phenotypes of early, I hope you can read the images, of infantile onset that happens early on within 6 months of life. These children present with significant motor problem, muscle weakness, heart enlargement that can be seen on imaging, with specific finding on ECG or the heart tracing that sometimes the cardiologists are even able to say this looks like Pompe disease. And this has actually happened in our hospital. With this early onset, there are not many neurological problems, and of course, children can have enlarged tongue, they will have some laboratory abnormalities. The other side is the late onset, mostly manifesting with muscle problems, with weakness, inability to perform functions that the person was able to do. from that aspect, we are now seeing a new phenotype result of early treatment for children with enzyme treatment. So while there is significant improvement in the heart status, there is still muscle involvement, mostly the distal part of the muscles. Those children may eventually require some respiratory support overnight. There may be some developmental aspect, but mostly those aspects are considered to be of the aspect of learning disabilities. And this is an image, you can see the X-ray with a really large heart of an infantile Pompe disease. The picture below it is an echo or ultrasound of the heart showing enlarged heart, enlarged interventricular septum. And as I mentioned, the ECG or the tracing of the heart is really pathognomonic for Pompe disease. We all know that muscles are significantly involved in Pompe disease, and that assessment for our patients is done usually with physiotherapy, occupational therapy, doing the 6-minute walk test. But nowadays there is more tendency to look into the muscle status from MRI aspect. And this was a study done by Dr. Kishani, who looked into a number of pediatric patients, and you can see majority of the muscles in the body are involved. The process that happens because of the destruction of the muscle is involvement of the muscle with fatty tissue. And the younger the patient, the younger the onset of that process happens. I apologize for my voice. So this is a study on adult onset Pompe patient, and I'm sorry that I cannot point out, but you can see the first group of pictures are showing the thigh muscles, and you can see the muscle, the relatively healthy muscle tissue is the dark one. The lighter one is the one that is involved with some fat infiltration. What they are showing is that probably using MRI of the muscles would be a way to, in a different aspect, assess the muscle status. What I wanted to show you, the second picture, is a picture actually of an adult person in his 40s who is very active, very sporty person, and they have again identified muscle involvement mostly into the perispinal muscles, the abdominal muscles, and if you can look at the last, the last upper picture, on the upper corner, right corner, is the image of the head, and you see a white mass or whitish tissue, which is actually the tongue, and the tongue already has some fat material. So I think going forward, we will need to incorporate MRI into assessing how our patients are doing. Apologies.
He hasn't given us any blanks yet.
Another aspect of involvement of Pompe disease in our patients is involvement of the nervous system. There hasn't been really systematic review and look into this. I don't think centers necessarily on a regular basis arrange for such assessment. Of course, we assess our patients, we examine them, but a study of initially 600 and then much significant smaller number of papers that were reviewed, and this review was done by the group here, shows that there is a variety not of only clinical manifestation, but also finding that one would see on MRI. We know that children will have hearing loss, and it is felt that it is due to the glycogen being deposited in the nerves and also in the brain. The presentation can vary from children to late onset patients with Pompe disease. There have been reports of stroke, there have been reports of transient ischemic event. So this is something that will need to be prospectively monitored for all our patients. Not to go into details in the pathogenesis, but there are two parts that are important into why Pompe disease is presenting. On one hand is the metabolism of glycogen. We know that the glycogen cannot be metabolized, but there is a notion that probably there is even increased synthesis of glycogen, so that adds on the burden of the ability how to degrade glycogen. The other component is autophagy. This is a process that every cell has, and it is really has been evolutionarily presented through all the species, because it is important to clean up our cells from what we don't need. This process is important into transferring the enzyme to the lysosome. So if there is no good function, this process will be additionally affecting the tissues of a Pompe patient. And now the diagnosis. We can talk, I think, just one talk about diagnosis. Now, I have only one slide to mention them. The diagnosis is based on enzymatic therapy with a blood dot card. If this is positive, then further enzymatic testing using different enzyme modes is being confirmed. We use biomarkers, for example, CK level or the muscle enzymes. It is usually elevated in patients with Pompe disease. We can measure the urine hex, which is elevated. So markers that do support the diagnosis. For especially children who present early on, and you have heard, I'm sure, the CRIM status is important to know. The word CRIM comes from cross-reactive immune material. So patient can be positive or negative. The positive means that that patient has some amount of protein, so the enzyme that is being delivered will not be completely foreign protein. It is important to know this from the aspect of prognosis. The patients who are CRIM negative have more reactions to the enzyme treatment, tend earlier to develop antibodies, and therefore protocols which we have used for patients are managed to decrease that immune response, and we use a variety of medication for immunomodulation. And of course, the final diagnosis is the molecular testing. The treatment, it's really a team effort, including the family, because the biggest burden is on the family. So we have both metabolic physicians, neurologists, cardiologists, respiratory physicians, the role of the speech therapy, physiotherapy, occupational, and definitely dietitian. So this is a team effort to really optimize the status of the patient. Sorry. And now we will switch to the next part of the talk, which is the treatment. This image shows all the modalities of treatment, some that are really currently approved and we are using them, but many others that are in the pipeline and really give us promise for treatment. The first one that I will discuss is the only currently approved treatment, which is enzyme replacement therapy. So you can see in basically the enzyme replacement therapy is in a way imitating, not completely or not completely successfully, how the natural enzyme is working. So within the nucleus, you can see the gene that is encoding the protein. The information on the protein is further transferred into certain organelles, and that initial protein is being metabolized to active enzyme. And the enzymes in our body undergo glycosylation, phosphorylation, all processes that make the enzyme work well. The important component is that they are very abundant with mannose-6-phosphate, and that way they are very easy to be accepted in the lysosome. So the mannose-6-phosphate receptors you can see on the upper part of the image is the same principles that enzyme therapy has this mannose-6-phosphate, which can be accepted at the receptor site and enter the cell. Currently, probably the majority of the patients are treated with glucosidase alpha. And this has really changed the outcome and the prognosis for our patients. For the infantile onset, this is a treatment that has allowed to really improve survival, to improve ventilator-free periods, to really normalize the heart status. For the late onset Pompe disease, this improved motor ability. You know how we ask you to do the 6-minute walk test, which is not an easy task. So improvement in that parameter, in the lung function, and usually we see a really nice peak and improvement within the few first years. It is administered every 2 weeks. Lately, what we are doing is we are actually giving it weekly for the children with early onset infantile Pompe disease. And of course, the reason why there are other modalities is that enzyme replacement therapy has some limitations. The biggest one is how that enzyme is distributed to the tissue, and we really want distribution to the muscles. The muscles have big surface, big amount of tissue, and relatively low number of mannose-6-phosphate receptors. So this led to development of what is called second generation enzyme therapy. So the glucosidase alpha is the second generation therapy that the benefit of this treatment is additional groups of mannose-6-phosphate. That means that the enzyme will be targeted easier to the receptors, the enzyme will be uptaked faster and better and provide better clearance. It was approved in Canada in 2022 as Nexviazyme, but you have to be aware that the approval is for late onset Pompe disease, who are ambulatory, who have never received myozyme, or they cannot tolerate myozyme. On the other hand, patients who are really severe, they will not be approved for glucosidase alpha. Another way to really improve the effect of the enzyme is a combination of enzyme therapy and chaperone therapy. So chaperone are molecules that are used to assist the protein in achieving its correct configuration. And it is known that some of these chaperones can even have positive effect to our natural enzyme. So I can show you a trial that looked into, basically this was a randomized trial into a big number of centers and maybe 24 countries. The number of patients was around 120. They were randomly assigned to two arms. The one arm received the new enzyme, the glucosidase, with the chaperone miglustat. This is a molecule that is already used for other disorders. The other side were patients that were randomized to glucosidase alpha and the placebo drug. The outcomes of this study were first the 6-minute walk test, and the second one was the pulmonary function. While there was no statistical improvement within the first outcome, there was improvement within the lung function. So this led to very recent approval of this combination of therapy for Canada by Health Canada just a month ago. So we have two components of the treatment. One is the infusion, the ciproglucosidase, administered every 2 weeks, and then the miglustat, which is oral treatment. The dose depends on the weight of the patient, whether they will be given 3 or 4 capsules. Important to say that it is approved for late onset Pompe disease for patients who weigh more than 40 kilos, who are ambulatory, and who have at least FVC or pulmonary function test above 30%. The benefit is, on one hand, having the chaperone treatment, which stabilizes the enzyme, and it allows better distribution to the tissue, and also the enzyme itself has been enriched with more molecules of mannose-6-phosphate. So currently there are really many trials with enzyme replacement therapy and variety of formulation that are used. One of the interesting trials is basically providing enzyme therapy in utero. This was a multi-center study. The patient that I wanted to show you actually was treated in Canada. I believe everything happened in the era of COVID, and the patient couldn't travel to one of the sites. This child was born to consanguineous parents. So the graph, the left upper quadrant shows the family history. The double line shows that the parents were related. The round circles present a female, the square presents a boy, and the triangle a missed or lost pregnancy. Unfortunately, this family had 3 children who had Pompe disease. Only one of them was treated, and they passed away. So the 4th child started to receive enzyme therapy at around 24 weeks of gestation. It was given through the umbilicals as an infusion therapy every 2 weeks. After delivery, the baby received immunomodulation, which we use as well. And currently, the child then continued on enzyme therapy. So by age of 13 months, the child had actually, even at birth, no signs of heart involvement, no muscle involvement, and is developing well. And you can see that the other parameters are really within the normal range for the patient compared to his siblings. The image of the heart again shows that at birth the thickness of the heart was normal compared to the sibling. So what are the challenges? I think I mentioned one of the biggest challenges, the distribution and targeting of the enzyme therapy. There is also the associated reactions. We know that happens. Development of high sustained antibodies towards the enzyme, which may make it inefficient. All of this leading to inadequate clearance of the glycogen. And I should not tell you the burden of life for the patient, for the families with bi-weekly or even weekly infusions really affect families. And because of those limitations, there are some new phenotypical or new findings that we see in our patients, both from the aspect of the vasculature, the heart, the GI system, but even the bones and the central nervous system. From the aspect of the heart, there will be rhythm disturbances. There are no changes in the vasculature that can happen. From the aspect of the GI tract, children can have heavy bowels, bloating, abdominal pain, diarrhea. There have been cases of described fecal incontinence. Because of the lessened stress on the muscles providing to the bones, there is the risk of osteopenia and osteoporosis. The so-called rigid spine syndrome is more seen in teenagers with difficulties of moving the spinal part as a result of muscle contractions. And we did mention the complications in the central nervous system, because we know that now glycogen is being deposited in tissues and the current enzyme therapy cannot reach that. This leads to the next type of treatments. The substrate reduction treatment is starting to modify the process at a different level. And I like this graph. So the upper tab, the most higher tab in the picture, is presenting the muscle glycogen, which is almost empty, and you see the faucet running glycogen, and then on the output you see the metabolized glycogen. With Pompe disease, unfortunately, the ability to metabolize is low and the tab is quite full. With the enzyme replacement therapy, what we are doing is adding exogenous enzyme, which tries to improve the degradation, so definitely the level is lower. Substrate reduction therapy works at a different level. It is trying to decrease the production of glycogen. So you can see there is less water coming from the faucet, and the level of the glycogen in the muscle, or in the picture on the tab, it's decreased. This is a well-known treatment that is used in other metabolic and lysosomal disorders, and this image shows where the substrate would be, the substrate reduction would be working. The synthesis of glycogen is particularly controlled, and it is the rate limiting process by, you can see, JYS1. So it's a glycogen synthesizing enzyme, which, if it is inhibited, the production will be decreased of glycogen. Therefore, inside the lysosome, there will be not a huge load of glycogen. Animal models have shown that by inhibiting this enzyme, the amount of glycogen in the cell is decreased. And there are even genetic conditions where different genes that control enzymes that activate or deactivate this GYS1 can lead to decreased glycogen in the cells without any pathological effects for the individual. So by this principle, the next slide points on a new molecule, and I made a misspelling, and I hope the company will forgive me. The product is MZ101. The E is a mistake. So they have first tried to use it in a mouse model where they just compared on a period of 12 months treatment with enzyme replacement, only substrate reduction, and combination, which is the blue, the light blue. And you can see the light blue, still there is some glycogen residual in the muscle, but it is significantly less compared to the other modalities of treatment. It has been trialed, this MZ101, in a clinical trial, phase 1, which showed really good safety data, and a phase 2 is being planned. The fact that this mechanism or this process works shows that other centers or other researchers are trying to utilize different molecules with the same principle, trying to decrease the glycogen synthesis and therefore less burden for the cell. And I think the last group of treatments is what we're all looking forward to, is gene therapy. The benefit of gene therapy would be the ability to bring a functioning gene into the body that will correct the defect that is present. There are a variety of vectors that are used. Mostly those are viruses, retrovirus, adenovirus. The currently mostly used are the adenoviruses, and they are engineered. Therefore, they do not incorporate into the genetic information in the patient, and they're also not known to cause human disease. But of course, there are some concerning components or challenges. First, how to produce the vector and the best vector for it. There is still some degree of immunological response, definitely not at the level of immune response that we see with enzyme therapy, but it is present, and the fact that there may be need of redosing. The type of delivery can be systemic, or there's also attempts to do muscle only or even CNS delivery, because otherwise the delivery may be not well distributed. One of the first phase 1 studies was done in patients with late onset Pompe disease. The patients were followed for 52 weeks. They were all pre-medicated with steroids. And the follow-up did show, first of all, this was a safety study and showed good safety outcomes. There was increase of the enzyme in the muscle tissue. But some of the parameters that were monitored maybe did not show excessive improvements. But again, the goal of this was to see more the safety. I was quite excited with this study, which was reported 2 months ago approximately in the New England Journal of Medicine. Sorry that it's a bit off the slide, but you can see that this was gene therapy with adenovirus for 4 infants who initially were treated with enzyme and subsequently received gene therapy. One of the infants started to deteriorate, needed to have more invasive ventilatory support, and the family did not want to proceed, so they exited the study. I think what is important, if you look at the second group of graphs, the first one shows the score, the developmental score. The higher the score, the better performance for the child. Patient number 1 has dip in many assessments, and it seems that this correlated with infection and pneumonia. The second, under B and motor milestones, you can see that all 3 patients who had gene therapy achieved the ability to sit, achieved the ability to stand and to walk, and also the ventricular mass, the size of the heart improved significantly. And one image, not necessarily of the same study, shows infant who at 3 months was diagnosed with Pompe disease, received enzyme therapy, and then received gene therapy. You can see on the lowest part of the image, the right under F, the heart size has significantly decreased with really good outcome. And I mentioned that the vector, or how do we introduce the gene, is a challenge. One of the factors with the gene therapy delivered with adenovirus could be some toxicity or some reaction. So there are attempts to use different molecules to introduce the genetic information. This is also a way of trying to find different molecules that could do such a job. The current slide shows mouse model where they used cationic lipid molecules which are capable of transferring the genetic information. And they noticed into the mouse that was treated with this gene therapy improvement in the ability to walk on the treadmill, and also improvement in the muscle strength. And of course, this is one of the type of genetic therapy where we are trying to incorporate the gene, Another possibility, and I didn't even go there, would be trying to edit the gene using the now well-known CRISPR-Cas9 method. But again, this is just a small number of studies that are ongoing with gene therapy, and both gene therapy and enzyme therapy, you can see from 2006 when the first enzyme therapy was improved and going to today, there has been explosion of trials of introduction both of new enzymes but also gene therapy. Going forward, what do we want to achieve as an optimal treatment? First, treatment that would target the tissue that really needs to be targeted. The other option would be treatment that is not so invasive and you don't need to go every 2 weeks for infusion, maybe just an oral medication. And of course, gene therapy that would hopefully completely cure the disease. So with this, I will stop and thank you for your attention. And if you have any questions, please let me know.
So I have a question. If nobody else does, right away. We're on.
Yeah.
One of the things that I've kind of learned going into this as an LOB patient, as an adult, it's quite a burden having this disease. Like there's treatment, there's ongoing medical care, there's like so much medical overhead. And I can't imagine what IOPD families go through.
I agree.
Can you think of anything that we can do that, we're doing everything we can medically, but is there any other sort of support mechanisms or anything like that that you can think of that we could do to make their lives just a little bit easier?
Well, I think, even from our aspect, from the medical institutions, this would be my goal and ideal, and potentially other centers are able to do that. Not everybody lives near the center of treatment, and they need to come for cardiology and then for pulmonary function tests. So trying to make a more of a patient-concentrated treatment with seeing all the needed specialists to a degree, not to be overwhelming, but maybe in 2 days rather than coming every couple of months for a variety of assessments. Unfortunately, they are needed. They are needed for us to know that there is improvement and also for the approval of treatment. I think communities like what you have developed is really important. To provide support to each other, to provide, guidance in a way, and advice of what works and what doesn't work and how to cope. The community where patients live, I think, could be better involved. It probably depends on the resources there. The resources are everywhere, really, really scarce. So I think that all requires further, maybe financial support for that to happen. But from my aspect, I do feel that even the care within the centers can be improved with more patient-focused care.
That'll evolve, right? As more centers get used to dealing with rare diseases like this, it's just one of thousands.
Yes.
So as that happens, then centers get more personalized in care. So I think that'll kind of be an ongoing thing that will improve, which will be great to see.
Yes,
like in a perfect world, right?
Thank you.
Yeah.
Anybody else? Are there any clinical trials in Canada going on that patients can be more involved with?
I did not specifically look, but I believe there are mostly for late onset Pompe disease. And mentioning the clinical trials, I really want to put a plug that those are important. I know they require lots from the families, but those are the ways that we can get back information on what is useful, whether things are improving. Of course, their primary goal is safety, so I don't think families should be worried that there will be no checks and balances with regards to the safety, but I would really encourage families to be involved. I think there are probably several studies, at least one that is ongoing in Canada on adult Pompe disease.
Just on that topic, I wanted to just say that you only see your physician probably once every 6 months or so. You can reach out to us anytime, and we do monitor what's happening out there. So we'll know what trials. We don't know everything, but we'll be able to help you get connected and know what trials are available. Some don't come to Canada, unfortunately. We've had patients in Canada who have had to travel to the US to participate in a trial, but some do. Some come to Canada first. So don't think just because we live in little Canada that we don't have clinical trials here. And one of the nice things about a clinical trial is that you've got ongoing care because of the clinical trial, and you may get more insight into your disease and your state of health than you would otherwise, which I think is quite a significant benefit. So don't think just it's a clinical trial. I don't want anybody to experiment on me. Don't think that. This is your opportunity to access a therapy that's just not available yet. So you really consider it if it comes up.
Yeah. Yes, and I, as an example, I will give the immunotherapy that we now use for the infantile onset Pompe disease. There were trials that show that it works, and now we have patients who have gone through the immunomodulations and who do not have any antibodies, although they are on a weekly double dose of the enzyme. So that knowledge comes from somebody who previously took part in a trial. And we are grateful for that, of course.
I just wanted to ask about the CK level. It seems to be very unpredictable. And if there's any way that we can kind of understand, how it comes and goes, because my grandson it just seems to happen, and then we have to deal with it after it happens. Is there any optional way that, or any studies being done on that area?
Yes, so definitely that is a concern, and I think it goes to the point of how well the enzyme is entering the muscles, and also to the point after a period of really improvement and good results, things slightly slow to decrease in effectiveness from the enzyme. So the question will be whether your grandson would be eligible for any other type of enzyme that may have a better mannose-6-phosphate markers and potentially lead to improvement. I don't think that there is treatment-wise anything else that can be done for the high CK. Of course, we always say make sure he's hydrated well, which I know he does. Probably the level of activity just prior to the sample may have contributed, but it is reflecting the fact that the enzyme probably is not reaching the muscle and functioning at the level where we want to. The question is whether higher dose can be used, and that is something that we need to look into.
I was curious about, sorry. Thank you. I've heard a couple of things about physical activity during ERT, assisting with the muscles uptaking the enzyme. Is there any truth to that at all, or is that helpful?
I mean, physical activity in general is good for patients with Pompe disease. You want to maintain, and I think there will be later on discussion more about that. I'm not sure that is the case, because if you're active and you are also, at least in our pediatric patients, we monitor the heart, the blood pressure, then we will start to worry, at least I will be worried for sure. Is this something as a reaction to the medication, or is it just the activity? So I know that there will be discussion about that later on, and maybe experts in that area can make a comment.
Dr. Tarnopolsky at McGill actually looked at patients and had them ride the bikes as they were getting their enzyme replacement and found no difference.
So don't stress yours or whoever is your family member, providers of the treatment. Okay, thank you so much.